It is 12:32. We're going to get started. So I'm just looking through the glass over there for our the signal that we are. Well, welcome everyone to our Board of Health meeting this April 24th, 2025. And looking forward to our agenda today. Let's start with a roll call. I'll call the meeting to order. And let's start with, that was loud. Sorry, I woke up Dr. Velasquez over there. Let's start with Michael Cathcart.
Michael Cathcart, present.
Amber Waldriff, County Commissioner, present.
Michelle Fossum, Legal Counsel.
Ann Pittsnoggle, Recording Secretary.
Monica Blakowski-May.
Mary Keeney, Spokane County Commissioner.
Josh Kern, Spokane County Commissioner.
Dr. Velasquez, Health Officer.
Alicia Thompson, Administrative Officer.
All right, welcome everyone. And Charlie Duranova did reach out yesterday to let me know something came up last minute. He wasn't able to come today, so we'll miss him. But do we have anyone signed up for citizen input?
There's no one signed up.
No one right now, okay. Then we'll go to board reports. So I'll start with the chair report. I don't think I have too much to report new and different, but we had a good meeting last week preparing for today's meeting, and lots going on at the health district as always. So I know we'll probably get some updates from Dr. Velasquez on the health side, disease side, and from Dr. Thompson on our programs today. So looking forward to that. And then Commissioner Cuny, did you have a report from the Budget Finance Committee?
So we met last week at our normal time and went through the vouchers and financials, and everything looks good. There's going to be a couple things that Kim is going to be talking about during her finance report, that we talked about some of the fund balance, some need for using some of our fund balance that will be coming before us. And I think that's about it.
I know Kim was excited to give us some of the numbers, almost closing out 2024. So looking forward to that. And was there another committee meeting?
No, there's not yet been another policy meeting, but okay. There may be another pulled together per some of the conversation in last month's meeting. So. Okay,
great. All right, then moving on to our consent agenda. We have the meeting minutes, March 27th, 2025, and the vouchers from March 1 to 31, 2025. Do I have a motion to approve the consent agenda?
So moved.
Second.
Okay, I have a motion and second. Any discussion on the motion? Seeing none, all in favor say aye.
Aye.
Aye. Any opposed? Okay, we've unanimously approved the consent agenda for today, so we can roll right into our reports.
Yes, thank you.
And we worked really hard to make sure we had an agenda today that we could get done in a reasonable amount of time, because there's so much going on, so we're doing our best. So thank you. Take it away,
okay.
Dr. Thompson.
Thank you. So just a reminder of our emergency exits and where our restrooms are for our community members in the audience. And then this is the agenda. We're first going to talk about some staff kudos.
You know, you're a little bit low on the, maybe just pull that mic up a little bit. Maybe it's being recorded fine.
Christian, can you let us know if this is recording fine?
It's just a little bit low.
I don't even know if it's on. Should be on. Yeah, it's on.
If there's a way to pull it up close. You're just so
Sure.
tall.
I know. Yep. Okay.
Okay, we'll
How's
do it
that?
that way.
Is that better?
That's wonderful, thank you.
Okay, so I'll go over the staff kudos, and these are the top 3 that were selected by their peers at SRHD. Then we'll go into the SRHD treatment services update. Okay, so first up is Termaine Turntine. And the people who submitted this, they said yesterday in the exchange, 2 individuals got fairly heated with one another, and threats were made and voices raised. The employees did not feel in danger, and they tried to de-escalate as best they could. Termaine had been standing outside and came into the exchange. He did not intervene in the argument, but his mere presence toned things down. One of the clients left, and Termaine was joking with him on the way out. Termaine continued to very actively listen to the other client rant on for another few minutes. Afterwards, Termaine informed us that he came into the exchange from outside because he saw gestures. He was able to recognize a possible threatening situation through the window from body language. To me, this is the pinnacle of great security. Termaine's ability to de-escalate a situation without saying a word has always been amazing. But yesterday, I was in awe. He routinely builds relationships with our clients based on mutual respect and goodwill. It makes all the difference. Next up is Jennifer Hansen. And Jennifer Hansen is a public health expert who has spent nearly 20 years leading transformative community health initiatives in Spokane, particularly for marginalized families. Her work includes advocating for smoke-free housing, empowering young mothers, and revitalizing neighborhoods, all with a focus on health equity and collaboration. Jen's groundbreaking contributions have earned her the 2025 Education Award from YWCA Spokane, as she continues to create a ripple effect of positive change in our community. And next is Christian Montiel in IT. Christian is always very responsive to this employee's IT tickets that pertain to Christian's role. He's quick to communicate his timelines and is great at communicating status changes and completing in a timely manner. His love of learning new things is apparent in his efforts to help when he's not sure about something. He'll go back to a team member or investigate options to come up with a plan. He keeps that employee up and running, and they appreciate it. And I know all of us at SRHD that we get assistance from Christian also appreciate it very much. So to the 3 of you who are being highlighted for kudos, thank you for all you do for SRHD, and we are very happy to be able to present these kudos to the board. Okay, so now we're going to go ahead and present this treatment services update. The first is our finances, and so we ended the month of March $313,556 surplus. And so, do you have any questions about the finances? Okay, I'm going to pass it to you. Okay. And the next up is just our monthly numbers. And if you have any questions on the numbers, Adam's right here for you. But basically, I just kind of talked through it.
So each month, these are all the same numbers that we've been presenting to you each month, just with the most recent month being added into this with the collective totals being presented now. From dispensing intakes, our counseling sessions, physicals, and jail dispensing and so forth.
And so one of the things to point out is we've really been averaging right around that 968. I mean, it's really hovering. You can see that it's really hovering right around that same number. And those are unique individuals that are being served. Any questions about the data dashboard? Yes.
The counseling sessions, are those broken down by person too, like how many people you served, or just with do we have an idea of how many people received individual counseling sessions versus the overall number?
So for the month of March, so the individual counseling sessions, that 691 is for the entire 969 individual patients. Now that's just for the individual counseling. The telehealth included is also, so the individual counseling, telehealth, and group counseling, all three of those are collectively for the 969 individuals.
I guess
So-
what I'm asking is, are they people that come once a week or once every 2 weeks or once a month, or do you know, or?
All the above.
Okay.
We don't have it broken out as far as their take-home or their carry schedule.
Thanks.
Any other questions? Yes.
This is Dr. Blakowski-May. Sorry for my voice if you are not hearing me very well, but I just wanted a little bit of a clarification on annual physicals versus assessments, and clinically what that is. I guess I wouldn't think that treatment services would be doing annual physicals, but I'd love to know more.
Absolutely. So with OTPs, we have an obligation. The SAMHSA regulations also require that we have an annual physical. So it requires that our medical providers meet with the individuals once per year to basically get an update on their medical status and ensure that there's no new medical issues that have arisen, to follow up on anything that maybe they haven't been following up and communicating with the medical providers on throughout the last 12 months. The initial assessment process for the medical portion is that initial intake. So they are required to meet with the medical providers at intake so that the medical providers can then make the appropriate determination for dosage, which medication, and starting to work on that basis for take-homes with the clinical team as well.
Awesome. So intakes would be included intakes would be included under annual physicals.
No,
No.
that's the
Okay.
assessment. The assessment, sorry,
Oh.
assessment is the intake, but it's the medical portion of that. The intake for the counseling portion is the intake. It's just vernacular for medical versus the counseling portion.
Do you want to explain what are some of the tests we do?
Oh, with the medical team. So our medical team, especially at their assessment, when they very first come in, or their medical intake portion, when they come in, they have to have their EKG. We have to make sure that their QT is appropriate, and that all medications that they're prescribed don't have any negative interactions with the methadone or buprenorphine. We also do blood draws and check all the necessary requirements to ensure that if there's anything that's alarming or concerning, that the medical providers can then have that conversation with the patient and refer them to the appropriate providers or back to their primary care, or help assist them in obtaining a primary care physician as well. But we do all that on site so that they don't have to go out into the community and have another appointment scheduled, and we await that process. So it does help expedite that process internally.
Yeah, that's awesome. I didn't realize there was such depth there, so I appreciate that.
And we do the EKG regularly as needed, but we also do it annually. The blood draw is only the first time at initial intake.
Thank you.
Yeah.
And I guess who's doing that initial, the physical and intake?
Our nurse practitioners.
The nurse practitioners that we have, okay. And then, I guess kind of back to the question, in looking at the numbers on the medical side, the assessments are done at the intake, but our intake numbers, I guess I'm trying to relate those back to each other. Because it's like the intakes that were turned away versus the intakes that were returned and were admitted versus, I don't know what the transfers and discharges were.
So this, do we actually have, this might be a data point we want to add, the total number of
Oh, like
intakes.
new intakes maybe as a data point.
I don't think we have the total number of new intakes on here.
So the total number of the new intakes is actually the assessments. So the counselors call their piece the assessment, the medical actually calls their piece the intake physical, but those numbers are exactly the same. For last month, it was 44. And last month as well, the intakes just happened to be 44, or the discharges happened to be 44. So,
So what he's saying is it's not separated out, he's just got it collectively in there because it's the exact same.
we brought on 44, but 24 were turned away last month alone
Okay, so that's what that's saying is we did assessments for
for 44.
for 44.
And we had to turn away 24.
And we turned away 24 and discharged or transferred 44.
Okay, and does that then relate to the 24 that we had on the other page? If we go back to who we turned away, wasn't,
So what this is showing is, the board had asked us to show and track how many people have we turned away. And so on that line, all that is it shows that since January 1, we've turned away 52 people from services. But they did implement that new system where someone comes in and they have to get turned away. We're giving them a medical number, a medical record number, so that if they come back, then we can document here in that next line that the intakes returned and were admitted. So we had 14 who had been turned away in the past and returned to be admitted. And then transfers, discharges, that could be our total census. And so it could be due to they moved, it could be due to they decided they didn't need the support anymore. There's multiple reasons why people transfer and discharge.
no, okay. And I'm just trying to figure it out from the county perspective as we look at doing these additional funds is, so you do an intake before you turn somebody away?
No.
No?
No.
Okay. So that's a little different than we do have more people that we're turning away prior to intake that is not being accounted for here.
We're accounting for everything here.
So just looking at March, there's 24 unique individuals that when they very first come in, they're assigned their medical record number. Should any of those 24 individuals that came in, they return. When they return and are able to be admitted, that's what that next line is. So any of those 24 that came back in, those 14 individuals were already here previously. And now we're able to get them in. That's where that tracking is. So collectively for 2025 year to date, there was 52 individuals that we have unfortunately had to turn away, but out of that 52, we were able to admit 23 of them because they have returned back on another day that we were able to get them in. So that was a data point we hadn't collected last year that we are tracking now.
But yeah, maybe not to add, but it's like potential intakes who were turned away because you didn't actually do an intake. I think that's what you were getting at, Commissioner Cuny, so. But we understand what you're trying to say there, I think. And
So
it
just
could have
change-
been of the 14 that came back in March, they might have gotten a number in February and then come back in March. So it's not a month to month, it's just, so that's why the yearly total is helpful because you can see 52 tried to access services and almost half of them came back to do that. So, okay. Oh, Councilmember Cathcart, and then I'll go to Patricia.
Yeah, I guess could we see, is there a way to see how many are discharged because there's no longer a need for medically assisted support? Perhaps they still need counseling, but as far as methadone or something else, they've run that course. how many have graduated, so to speak?
Yes, I think we can look into that. I'll be honest, that number is oftentimes very far and few between. The progression for an individual to gradually taper their medication down is an exceptionally long period of time, just to help ensure that they're stable and they don't experience those withdrawal symptoms, but yes.
Is that the industry norm? No matter where you go, you're going to be there forever? Well,
No,
not forever, but for a
no.
very extended period of time?
It's all based on the patient desire and how they want to work that program and how comfortable they are, and making sure we are there for the patient and ensuring that their program is running as smoothly as it can for them. And in doing so, we want to make sure that, if they're looking at tapering their dosage, then we want to help work with them to ensure that they're minimizing any withdrawal symptoms, any cravings, using dreams, things like that. So we work with them and help encourage them to communicate with the medical providers on those issues so that they can taper at a pace that's consistent with what their body is allowing them. But yes, that is an industry norm to work at a slower pace.
And Dr. Velazquez wrote a really great article that was included in his health update. And so I'll make sure you get that, a copy of that, okay?
Board Member Keinholz?
Okay, so I have two questions, if I can remember what they are. So it would be nice to be able to tell, like, when you look at the jail doses, and it's for last year, 5,593 for 2024, and then you show unique jail dosing patients, 145. But there's no way from that number to calculate out the number of patients with the number of doses that they received. So, like, if you divide 5,593 by 145, that's not really going to give you an accurate number, because certain patients can receive more doses. So it would be nice if there was a way to track the number of doses with the number of patients.
And part of that's just going to depend on how long they're there, because one individual may be there for 3 days and another may be there for 6 months. So that's honestly going to be a huge variable in that.
Are you tracking that, and it's just not in this presentation, I guess is what I'm asking.
Yeah, we track because we have to account for the billing in that as well.
Yeah. It would be nice for us, I think, to be able to get an idea of how many people are using how many doses. Even in the treatment center. So that's one thing. And then the second thing I wanted to kind of tag on to Michael Cathcart's comment about, and going back to the discussions about being able to reward people and for abstinence, or the idea of being able to spend funds on events and things like that. Yeah, so I was looking a little further into this and through NIDA, and they were talking about contingency management as a behavioral therapy that uses rewards such as abstinent or treatment adherence. And so giving vouchers or gift cards are the kinds of things that we were discussing previously. And so I was just wondering if there is a way for us to be working on trying to reward something like abstinence, which then makes you eligible for other funding. If there's a way to build that into the program somehow, so that then you would be able to use funds for those kinds of rewards. And you have some feedback about that.
Sure.
Yeah.
And we're in the process of doing, I guess I'll call it kind of a deep dive agency-wide about what types of incentives or things are being used at the district, and making sure there's consistency and compliance with gift of public funds and some of those other issues. So we were just talking about a couple of days ago that we need to do that. So be happy to provide a further
More to
update
come.
down the road.
More to come, but that is on my mind, and I think it would be a way to bridge that gap if we could figure out how to do that. It's just that if people are consistently abstaining, then they're not gonna necessarily be at the treatment, seeking treatment because they're abstaining. So anyway, okay, thank you.
And I did want to point out that we do have the dispensing, so we have the total numbers of dispensed medications there.
Okay, Councilmember Cathcart?
Yeah, just real quick, do we have a sense of, with all the money that's flowing in, of when a plan for staffing and hour changes and just what that whole thing is gonna look like, when it's gonna be in front of us to review?
So, that was actually the next slide.
Wow, she was
Your
prepared.
question was perfectly timed. So this is our current operating hours of Monday through Thursday and Monday through Friday for our dispensing and office. And the proposed expansion hours are looking at Monday through Friday of a 5:15 a.m. to 6 p.m. with a Saturday of 7 to 3. And what that would do is offering all services throughout all 6 days a week, with the primary focus of walk-in and intakes being the objective. Now, that's the proposed and what we have been working on and looking at. We haven't put anything in motion, per se, as we have, this has all been working in progress, because there's so many moving parts to this with positions, PDs, what does that look like for availability and contracts and all the different pieces that go along with that. So this is what we've been initially looking at for the hours and days.
And right now, we don't have anything, you know, this has all just been conversations with the city and the county, and so we don't have any definitive that this is going to happen. But one position that we are actively working to fill is a policy specialist who can help us to really like get going on making sure that all of our policies and all of our standard operating procedures are up to date, because there were just recently some numerous changes in the SAMHSA and ATA, or whoever, you know all the acronyms. But we're trying to get that position filled. We know we do have the funding to cover the cost of that position, and that position would be helping us to prepare for this expansion.
Yes.
So the document that the city passed out to council members that was voted on Monday says that the expansion would mean we'd be open until 10 p.m. That's what the city had told council members was gonna happen. So that's why I was asking the question. That's what the document said, that the funding that we would be allocated would go to expand it to 10 p.m.
Those hours have never been discussed with us.
Okay.
Commissioner Kearns?
Can I ask, with the current operating hours, are those hours essentially driven by funding availability, or is that where the demand for this service is? I'm asking because the proposed hours, I mean, it's a substantial increase in hours. Is the demand there from 2 p.m. to 6 p.m.? Is it there on Saturdays from 7 to 3? So, I mean, it's great that you're expanding the hours, but is the demand for this service there to fill those hours?
We believe that the first few hours beyond 2 o'clock, absolutely, because you'll have a different populace that would be coming in that generally that has had to come in at 5 a.m. or 5:15 due to their work schedules. If their work schedule was such that they have to be to work at 5:30 or 6 o'clock, then this would give them the opportunity. The demand would definitely shift, because it may not be as heavily required for some of our patient population to come in at 5:15 or 5:30 if that availability was there and accessible to them at a later time. It may be more available and appealing to them to come in at a later time. So to answer your question, the demand, maybe not necessarily a demand, but a need for sure. It absolutely could.
So this shift, in part or wholly, you can tell me which, is to allow the existing patients to maybe shift to different times, or is it to accommodate folks that are not a part of treatment services?
Both.
Okay.
Absolutely both.
Okay.
Because one of the biggest problems that we see is that the limited hours that we have, which we've known for a long time it is a limitation, is that it really prohibits availability for individuals coming in off the street to come seek services, or individuals who are employed coming to seek services when they are off of their work hours. So if someone's working Monday through Friday, 8 to 4, but they can come in Saturday, that's an opportunity they haven't had before.
Okay.
And this is definitely an opportunity to expand those hours and allow a different populace of individuals to come see us that are in need of services that maybe they haven't had that opportunity to do.
Thank
And
you.
that, again, that would be our primary focus, is the intake process.
Doctor?
Yeah, so related question, but how many more, as we look further into this and sort of developing what information we would need, like how many more patients would we expect correlated with increasing the hours? So it's kind of a related demand question, but that's oftentimes how we look at things to say, okay, are we gonna break even on how many patients would we need to see to break even for the additional costs of providing that service?
And that's what we were attempting to do with the pro forma, but then we stopped working on that pro forma. And so right now, we are kind of asking a crystal ball question. We know that there's an extensive problem in Spokane County with opioid addiction. And so we know we're turning people away. We know that people have expressed to us that extended hours would be very helpful. And so we really don't know, but I mean, we can do a throughput study. We can see at like our really heavy times, we can see how many people we can throughput in a half hour. And then we can go from there and use that. And we'll do it a few times to make sure that it's a pretty accurate estimate of how many people we can get through the clinic in a half hour span of time. Now we know assessments take upwards of 3 hours, and they can take even more. So we're only talking about the dosing. So, okay.
I think we can also look at intakes too, and just as a average of what we have on any given day, between 2 and 4 to 5 intakes, we can average that out over the last, we'll say 3 to 6 months, and kind of approximate that. I think we can work on that over the next couple weeks for next month's presentation and kind of get you, and again, these are guesstimates. There's obviously no guarantees of what we can look at, but there's definitely no shortage of need, and I think if we can have this opportunity to expand, it would definitely open up our ability to serve the community's needs further.
Go ahead.
So again, just kind of as we're looking at this, because I know council's looking at it, I think we're going to have the discussion with Justin Johnson on Tuesday at the county. Do you have any kind of pro forma that you've put together as to what you think the need is and what those costs will be, so that we know that we're matching the costs? I mean,
Yeah, we put together essentially a pro forma of sorts and submitted that to Justin previously.
Okay, thank you.
Can I ask just so when the hours, so are these the current operating hours for every staff person, or just for when the public can access the treatment center?
So dispensing opens up at 5:15 and runs through 12:30, or I'm sorry, 12 o'clock. and the regular business hours for counseling group and all other services runs approximately 6 a.m. till 2 p.m.
Okay, okay. I was just trying to understand if there's still work being done by your staff.
Yes.
Even outside those hours. I'm sure there's still charting that's going on and other activities, but this would open up to the public both the dosing and the intake and assessment opportunities. Okay.
Yes, that's correct.
Yeah, I mean, I can't imagine that, I mean, if I was somebody that was having to get up and get to you guys by 5:15 in the morning, because my job started at 6:30,
Right.
having an opportunity to come after work. And I know we're not just doing this for current clients, but that frees up spots for other clients who maybe do want to come early before work. And so, right now, is there any challenge with people who are going in to get their doses beyond the limited hours? Is there any challenges with people getting those doses? Because I know you guys have a very efficient process of people coming in and getting their dose and leaving.
Okay, I'm gonna knock on wood.
Okay,
So with our current nursing staffing and our dispensing, they've gotten a very good process. And our clinical assistants and nursing staff have got it down, and they're very good at getting patients in and out. So the wait time is pretty, I know in the past we've had issues between our EHR system and being short-staffed, especially through days of COVID, where patients were waiting here in our rotunda for upwards of an hour and a half or more. Whereas now, I think our longest is about 15 minutes, 20,
well, that's great.
and that's on a rough day.
And we will need more dosing hours if the population grows.
And these would
And
be
that's
those
would be
dispensing
the-
hours.
Sorry, dispensing hours, okay. And so would Saturday be just mostly intakes or also dispensing?
All services.
Everything, all services, okay. Well, this is really exciting to think about because, you know, when someone's ready to go get assessed and it's 2:30, right? I mean, I think it behooves our community to think about, hey, you know, folks might want to go at 2:30 or 5 o'clock and at least get that initial number and find out that they can come back the next day for that 3-hour assessment, because it does take a long time to
Right.
get all the medical and the, make sure that person is eligible, right, to be ready to start dosing.
Absolutely.
Okay. All right, well, we'll look forward to hearing more next month after the city and county have deliberations, and when you know more about the dollar amount that you have to play with, and that may impact, right, the hours and,
Right.
but this is your goal.
Exactly, that's our goal.
Okay,
That's our
great.
goal. And our last item for this update is just a quick update on the SAMS contract. That is the contract for the electronic health record. SAMS was actually acquired by NetSmart, and so they're reworking our contract, and you'll see that next meeting. And you've already approved the SAMS contract, but we need to have you approve it as SAMS, as a division of NetSmart. Okay? So just a heads up on that. Okay? So thank you.
Okay, thank you very much for answering all of our questions, and we're learning a lot, so appreciate that to the OTP team. And here comes Kim. All right, we want to make sure you have a good time here good enough time in the agenda to be able to give us some updates from as you're closing out 2024 and looking at where we are.
Yes, thank you so much. Is this microphone okay? You can hear me okay? Probably easier to keep my hands free. So yes, I'm bringing forth 2024 financials today, and I'll just hit the advancement here, and then we'll briefly I'll reference the 2025 in the interest of time for financials.
Wanted to bring the mic just a little closer to you. I think that'd be great. Perfect.
There we go. Better? Okay, thank you. So 2024 does take a period of time for us to close out each year. We're always anxious to get that wrapped up. But we do have the state auditors that have a look-back period of 90 days, so any financial transactions impacting the prior year would be expected to be reported. So that's part of the delay. Some of it is also, we have contracts, and we need to get their invoices in, and then our administrative match through Medicaid administrative match is a quarterly billing, and it takes about a quarter to prepare that billing. So getting that final fourth quarter of 2024 takes a little time. So some highlights for 2024, our budget was $54,778,818, and we had 97% of our expenses. So we're under expenses. And then our overall revenue came in, our funding, at 101%. So in a nutshell, we have a surplus going into the reserves of $2.185 million. And some highlights related to why we have a surplus for 24. Previously reported that treatment services was running a surplus in that division of about it ended up being about $855,000 surplus. We also had some local dollar projects that we had anticipated, and they did not come in as high as anticipated. So we have a savings of $375,000 that would have been local dollars. I mentioned before, interest earnings were significantly higher than anticipated, so we brought in another $250,000 than budgeted for. And then we do have, each year we anticipate setting aside funds, which are local dollars, for separation costs and unemployment costs. So anybody that separates from the district and they're eligible for vacation or sick accruals, then we have to pay those out, and we can't bill those to the grants. They're ineligible. So we had a savings there of $575,000 that we did not spend in 24. And then one of the last items to note is it was time to do some replacement to our copier costs, our copy machines throughout the health district. So we did a replacement of about a third of our fleet. The cost was $116,000, intended to spend local dollars. That was part of our budget, but we actually had the opportunity to apply for a grant, and they are able to cover that cost. So that helps us bring the surplus for 2024 at the $2,185,000. And so what we did with the discussion about surplus with Budget and Finance Committee, and as what Commissioner Cooney had mentioned, is here is our goal for unassigned reserves, which is where that $2 million would go, is we want to make sure we're maintaining at least 20% of our overall budget. So we're at 26% at that point in time for year end. We still maintain the $1.5 million for the emergency board approved fund, reserve fund. But we did have a dialogue about acknowledgement that we have the 8th Avenue building as well as the West College building. So we previously had a $500,000 assigned reserve for unexpected building costs. So we bumped that up to $1 million. So wanted to let the board know that of that $2 million surplus, we did, through consultation with Budget and Finance, increase that to $1 million. The building projects, I just collapsed the two previous reserves for assigned building that used to reference the ADA improvements and the Clean Energy Act. So just those two numbers are combined and anticipated to be projects in 2025 and possibly into 26. The Information Technology Reserve was there at the end of 23 or beginning of 23 into 24, and that's just the timing of some Surface Pros that we purchased. They could not be delivered in time to the health district to be counted for as 24, and they were received in 25. So that's been exhausted in 25, just a short-term shift there, and that was on the previous reserves. We updated the EPH solid waste, EPH food, and EPH schools reserves. Those are the fee-based programs within environmental public health where we monitor to make sure that our fees are covering our costs, but that we do not make a profit. And if we do have a surplus in any one year, we put it out here in the assigned reserves and then monitor it against the next year's fees and incorporate the use of those fees or those surplus funds to keep our fees stable. I believe for 2025, EPH is anticipating utilizing almost all of those reserves to keep us whole and keep the fees the same. The next item back up is the EPH software upgrade. Acela is the software that EPH is using now. It's on premise, so it's not a cloud-based system, and they've been working to implement to the cloud and do some upgrades with that software. What we found is that the project's taking longer than anticipated, and we have some additional costs due to some customization and some scripting that needed to be written. But what we have determined also is that the treatment services EHR with the SAMS contract is coming in less than we had put in reserves. So with dialogue with budget and finance again, we shifted $150,000 away from the treatment services EHR replacement that was at $500. We dropped that to $350, but we did increase the EPH software upgrade by the $150. So just a shift within the assigned reserves and for 2 software projects. And then I think that covered all the assigned reserves. So we have $4 million in assigned reserves, and then our total reserves are at $19.486 million. Any questions on 24 or comments? Yes.
Commissioner?
So Kim, as we talked about in budget and finance, that with the reserves that are in solid waste, food, and schools, that those are going to probably get
Depleted this year.
Yeah, depleted this year, and so we'll be looking at fee increases because we do try to keep those where they're whole, so that the fees cover the costs of that. So just that will be coming before us as we start to look at the fee schedule before budgets. So just wanted to put that out there that will be happening. I just met with Ray again to just kind of go over that. So there's additional committees that advisory committees on the food and on the schools that will be looking at those fee increases before it comes back to the board. And then I know with solid waste that there's additional state laws that have come into place in the last 2 years that are really driving some of those additional costs. So it's just what it is.
Thank you. And then the last item, it's not on the slide, but you do have March of 2025 in your packet. So I'll just briefly cover that. We are on track for the year for March. We're currently at a surplus of $581,000, and that is primarily from the Foundational Public Health Services and the funding being received in advance of payment. We receive it in January, and it covers 6 months, so we're a little bit ahead there. We have not billed for March grants, so the federal and indirect federal and state have yet to be billed. So overall, we have a 26% unassigned reserves, or we're at $20,427,000 overall reserves. Thank you.
Great. There's no other questions? No? All right. Thank you, Kim. Dr. Velasquez.
Good afternoon, everyone. So I have a brief health officer report, just bring you up to speed on many of the areas that we have been following for the last couple of months, and so including some of the national news about the measles outbreak in parts of the country. So first thing we're going to talk about is pertussis, which, believe it or not, is still with us. We're keeping our fingers crossed that it's going to start to go away, although it doesn't seem to be wanting to do that. But if you look, and I'm not going to go through all of this, this is mainly for public information, so everybody's aware of the symptoms in case they see it. But we have about 888 cases in the state of Washington, which is a little bit higher than what it was last month. So we have not seen, although we've seen a little bit of a slowdown, we have not seen a significant decrease because we saw a little bit of an uptick in the last couple of weeks. Spokane County continues to be top right now. As of yesterday is 199, so there's an additional 20 cases compared to when I put the slide together earlier during the week. And we do have the most significant number of cases, not only based on population, but total number of cases thus far. Now, when you look at the graphic representation, you can see that from March to April, we started to see a little bit of a dwindling. With the new graph that we just got last night, when you add the first a week and a half or two of April, you see a bump up. That is actually 12 and 12, meaning 12 cases, 12 cases. So we saw a little bit of an uptick, which we've seen that up and down over a period of time, although we started to see a downward trend earlier in the year. So we're still tracking that, and obviously in communication with our providers and our schools and all of the other environments where we could see the spread of disease. So we'll keep our fingers crossed that the last couple of weeks are artifact because of spring break and everybody moving all over the place and being exposed to each other, and that will settle down as we go forward into the last few weeks of April and beginning of May. Now, one of the questions that people ask me, is it focused in one place? And if you can tell, yes, you can tell it's spread pretty much almost anywhere. Home seems to be a very common environment. Obviously, healthcare, K through 12, and K through 12, I do have to say our partners in K through 12 do a great job of trying to keep things contained and providing education to parents, etc. So we know because we hear from parents. I got a letter from the school, which, you know, it is important to do, but it's not any specific area. It's just pretty much all over the community. So the awareness is, if you see a child with any of the symptoms, if that's your child, make sure you're consulting your pediatrician or provider to make sure that we're following the appropriate steps. And if you have been exposed and you're part of the household, there is some post-exposure prophylaxis that could be useful for you. Yes?
Is a household, is that considered to be 4 people or 2 people, or is there
A household is
norm?
defined as however many people in the family. And that's a good question because sometimes our households may have as many as 30 people. We do have in Spokane, in some areas of the community, multi-family, multi-generational households where you can have, 20, 30 people, and we do worry about those with communicable disease, not only pertussis, but other diseases. Now, the good news is even in households with higher number of people, we have been able to do post-exposure prophylaxis, and I have a good sense of that because I sign a lot of the prescriptions if they don't have access to healthcare. And in the household, many times we have 2, 3, 4 people that are being treated. So, good question. It will be interesting to see how we break down. Don't know if we have that data for each one of the households. Good question. Yeah, household is an interesting definition just because of the number. So we are giving you probably, hopefully, it's a final update in Shigella, which has been contained. We have not seen any more, knock on wood. We don't really want to see any more compared to what we saw last year. But it's something that we still track, and we're still enhancing awareness, particularly with shelters and other providers where you could see that, although if you recall, when we showed the distribution was pretty spread, wasn't just in one specific area or one specific environment. And I put that zip code map so you can see that the cases that we saw were in a wide distribution. It wasn't just in one area or related to one particular environment, which is one of the questions that people have. So the moral of the story is, hand washing, appropriate hygiene is the best way to prevent this. Doesn't really matter in the environment that you may be at. So always be mindful and careful with that. And as we get into the summer, we're gonna have for the 4th of July food safety, as we did for the Super Bowl, because people eat food and touch it. So let's talk a little bit about the bulk of respiratory illnesses. And we all know someone that is sick. We all know someone that has been sick. And we all know someone that is getting sick. And the issue behind that, although we have seen a little bit of a significant downward trend, the respiratory illnesses are still with us. And I'm going to talk a little bit about the flu because this flu season is considered to be a severe flu season for the nation, comparable to 2017, 2018, which is the last time we had a really severe flu season. and I will explain what this is, but anecdotally, 2018 is when I stopped working, retired for 3 weeks, got the flu, so I'm never doing that again, because that's bad
So-
karma.
Don't retire.
No, I did that for 3 weeks, I got the flu, and I, knock on wood, I usually get a sick day every 5 to 6 years. Knock on wood, I'm very thankful and very helpful for that. But going back to the overall country, what you see here is basically a projection of what could be the cumulative hospitalizations for this particular flu season as compared to previous flu seasons. And these are the other flu seasons that we have. And as you can tell, 2017, 2018, which is the one I just alluded to, was the highest number of hospitalizations that we had. Now, the reason why this is a projection is because we have not completed the flu season. We're tracking on the basis of the cases that we're seeing, and we still have over a month to go. So hopefully the top projection won't happen, because that will be over 1 million hospitalizations, which is a significant number. If you look at the CDC data, this is where we're at. So the last couple of weeks, which is about 80 plus million illnesses, about 36 billion medical visits, about 1.3, about 600,000 hospitalizations, and about 26,000 deaths, including 10 pediatric deaths around the country. So needless to say, this is significant. And we have to remember that although the flu went behind COVID in attention over the last few years, we do have to remember it's still the kind of the most significant respiratory illness that we tend to see seasonally, is something to be mindful of, and flu vaccine works really well. The bulk of the cases, close to 90 or 91%, is A, influenza A, about 9-10% B, most of it H1N1, H3 and 2, which are the two components of the main vaccines that we have. So just for people to be aware. So anybody with symptoms, check with your provider and see if it's appropriate for you to still get a vaccine. And obviously follow good precautions like we see in the room. Thank you. We appreciate that. So we're going to talk about a little bit of measles, which is in everybody's minds nowadays. And we just did a Facebook Live on measles on Wednesday with Jenny from our EPI team and Kayla from our immunization. And if you've seen the new format, it's like a talk show. It takes about 10 to 15 minutes. And I'll show you a couple of other things that we've been doing. And we're working on an update for providers, not a health alert. We did a health alert when we had the first case in Western Washington, but kind of an update. And the reason for that is because cases keep increasing. We have about 800 across the country with an 11% or so hospitalization rate. A lot of these were young kids. And we have 2 confirmed deaths, 1 under investigation, which may be confirmed over the next few days. And by now we've had reports in 25 states, including state of Washington. When we look across the border, the first time I showed you, we were talking about down here. Now we've seen that spread through the Canadian provinces fairly significantly. And the reason why I bring that up is because there's a lot of travel that people are thinking about, spring, summer. So please be aware of where you're going. Make sure you're checking your kids' immunization status, etc. Now, across the world, it's been reported also in about 57 countries. So if you're going to travel abroad, make sure that you have checked with your provider about any particular precautions. I do know that in some of the high prevalence areas in some of the states in the U.S., some of the pediatricians are recommending a vaccine kids 6 months and older. So, okay, this is a global map for your information. So I borrowed Kayla's presentation because it's really good, so I figure I might as well use it. And this is the main question we get asked all the time, like, when am I supposed and when the kid's supposed to be? So this is what we have, basically. And there is also guidance for adults, which varies, so you have to check with your provider because there are a number of factors that impact that. But you have to go through this, and you have to go through that depending on which year you're born to be considered appropriately immunized. Although we do know that folks born before 1956 or so, we presume that they have immunity because there was exposure at those time. Although, check with your provider. This is something that we send to our schools pre and post spring break. Again, we're in contact with them consistently. And one of the things I wanted to show you is the coverage that we have by age and in the county. And to be effective 100%, you need about 95% of the population appropriately immunized, which we don't have. We have some work to do. But I do want to say that we're making progress. And what this tells me is that all the messaging, all the information, all the communication is yielding results because if you look, we see bumps in the immunization rates in some of the key target groups of pediatric patients, which is good. So go team. Thank you to our pediatricians and schools and all of the others that are doing that. We would like that number to keep going up, so we got to keep working at it. We will keep pushing for that as much as we can. And this is basically a little bit of the trend, which, it's kind of flat, except that at that little bump that I showed you over here. And ideally, we should keep going up. I say ideally because I don't know that we will. I'm optimistic, so I always say we probably will. And if you're not sure about your status or your kid's status, that is free, which is my IR. You can have it. It has all immunizations in the state of Washington, so it's a good thing to have. Now, in terms of community collaborations,
Dr. Velasquez?
Yes.
Oh, could I just ask a question about the graph for those who've been, the children vaccinated? Do you have that graph that goes back further?
We do.
Okay. I was just wondering, my wondering was if that is a normal, the 62 to 69%, or those kids were born kind of right when the pandemic was at the height. So
Right.
I was just wondering if maybe some kids missed because of that time frame. But I was just wondering, maybe it's always lower for the 4 to 6 year group. I don't know.
Okay, good question. So a couple of things. So yes, we did see a dip in most immunizations, including adults, during the pandemic for a variety of reasons, access to care being one. But Spokane has trended lower significantly for the last many, many years. It's not a new trend. And those numbers are pretty consistent. They get a little bit better, they go down. They get a little bit better, they go down. So we have been on the lower side of percent immunized, pretty much most age groups for quite some time. So, yeah, good question.
Thank you.
I should have mentioned that. Good question. Thank you. So going along the measles, we just had this yesterday with our Region 9 partners. And one of the things we do is we try to share as much as we can of what we have with all of our surrounding counties, particularly those that are smaller. And from what I understand, the folks from Walla Walla were interested in participating, although they're not part of our region, but we're always happy to invite others. So there were 2 sessions that happened yesterday, and good participation, good information, and we'll keep sharing as much as we have of all of the things that we have. And this is something that we sent to schools right after everybody came back from spring break, which our communications department helped us put together. It's a very nice graphic that parents can take home, kids that can take home, teachers can give away, just to remind everybody of the importance and the fact that measles is still around. And remember that although we don't talk about it very much, measles can be fatal. And it can also have significant complications like pneumonia, encephalitis, blindness. So it's not just a rash. It's not just an inconvenience. It actually could be a significant illness. And we've had mortality in a number of the cases that we've seen across the country. From a school perspective, this is very important. If you're not up to date with your vaccinations and there's a case in the school, you have to stay away for 21 days, which is a significant impact to the students and the families. So we have to be mindful of that. And with that, I'm going to stop here and see if there are any questions.
Any other questions for Dr. V? Oh,
Thank
that
you.
was a really great report. Thank you.
Thank you.
For the detail. Excellent. Well, our last update here is legislative, and we're getting very close to maybe the end of session. So thanks, Lola, for being here to give us an update.
Absolutely. Let me figure out where I'm driving here, and I'll get us there. As you're all aware, from the time we worked through this presentation here until today, things have moved. So there's going to be a lot of discrepancy from what I'm reading to you versus what you're seeing up here, but we'll try to keep this going as quickly as possible. Let's start with knowing that the Senate Bill 1561, which I do not have listed up here, but it is the biennial operating budget, that was approved for a conference committee, and appointment was granted as of 4/21. So we do have 3 representatives looking at that. Currently, there may be an update past 11:15 this morning. Next on the list is 1531, and that's that communicable disease. But we found out just a bit ago that it was signed by the governor on April 21st. No, excuse me, I'm reversing that. But yes, signed by the governor on April 21st, but it's effective also April 21st, 2025. So it got moved up and moved through very quickly. House Bill 1946, clarifying tribal membership, was delivered to the governor today. Senate Bill 5577 for medical coverage was partially vetoed, but is effective on, the remaining bill is effective 7/27/25. And then House Bill 1157, governor signed this on 4/11, effective 7/27/25.
Lola, did you have any, if you could go back to, what was the piece on the HIV antiviral drugs?
Oh, I'm sorry, did I go right past it?
No. What was, do you know what was vetoed out of that particular bill? Was it more around cost, or how much would be covered?
So the portion of that bill that was vetoed was specifically around funding for it, because funding is actually covered under other regulation, so it would have been duplicative, so they removed it.
Okay,
Yeah,
thank you.
absolutely. Oh, back and back. I'm still learning how to drive. 1186 on the medication dispensing, was delivered to the governor for 23, as well as 1392 for the Medicaid Access Program. And then Senate Bill 5244 for the exemption for WIC program was governor signed on 4/4, and it's also effective July 27th. And then, let's see, we also have 5163, modernizing the child fatality statute. Rules Committee relieved of further consideration. The governor signed, excuse me, I'm reading all of my updates all at once and as quickly as I can, but governor signed on 4/22, so this will also be effective July 27th. And then under the substance abuse prevention and treatment, we have House Bill 1432 for improving access to appropriate mental health and substance use. President in the Senate signed on 4/24. And then House Bill, 1066, creating the dashboard to track the use of legal substances. We have not seen movement on this since April 1st. And then our solid waste, 1154, that was delivered to the governor on 4/23. 1947, to simplifying the Group B public water systems, that was governor signed on April 11th, and that's going to be effective also in July on the 27th. Senate Bill 1497 for waste material management systems, governor signed on 4/11, also effective on July 27th. And then the 5033 for the biosolid sampling for PFAS is delivered to the governor on 4/23. The last item on here is the 526 lead in cookware, and the update for that is that the Senate concurred to the House amendments on 4/22. That was very fast. I hope I didn't go so fast I couldn't couldn't keep you guys.
No, I think it was great to have it in the packet and then give us a few updates because things are moving quickly. So,
Any questions?
any questions? Okay, thank you.
Thank you.
So I think we've finished our staff and administration reports, and we're going to move into an executive session. So Michelle, do you want to, I believe it's what's on our agenda here, litigation, potential litigation pursuant to RCW 42.30.1101I. Is there any other purpose for the executive session?
No other purpose.
Okay. So what time, I know we tried to put about, we tried to allow for a lot of time, and we did move this exec session to the end so that if we had citizens wanting to give comment or participate in our here, Dr. V and Dr. Thompson and all the staff give updates, that they'd be able to do that and then potentially leave. And so that's why we moved it to the latter half of the agenda. How much time do you want to start with for executive session, Michelle?
Why don't we start with 30 minutes? I'd rather extend than have everybody sitting here
Okay.
waiting.
Okay, so 30 minutes. We will clear the room except for,
Board members, Dr. Thompson and myself.
okay, so let's say at, starting at 1:45, so we'll be going to 2:15, and we'll extend as needed. Thank you.